As Andy said, I used to run the NHS, and while I was running the NHS, one of the things I observed was lots of doctors and nurses and others who went and worked in Africa or India or wherever and came back refreshed, remembering why they were a doctor or a nurse, and brought back things to the UK from that experience. And I'm delighted to know that Thet are with us in the room, who organise some of those exchanges. So I started to encourage that. And when I retired from the NHS, Blair and I talked a bit more about this, and he asked me if I would look at what more we could do from the UK to support improving health in poorer countries through our experience and our expertise. Not necessarily our money, but our experience and our expertise, and that contact doctor to doctor, nurse to nurse, clinician to clinician, or whatever. So I went off and did that, and I wrote a report for him called Global Health Partnerships in 2007. Two big themes in that, but a third thing that came out of it. The two big themes were, first one is a plain obvious one, but needs saying, stop telling people what to do and start helping them to do what they know they already want to do. Because we are still very bad, whether we think about it or not, at trying to organise things for people in other countries rather than going along there and supporting and helping them with what they already know that they need to do or that they want to do. And the second big theme is that the biggest single thing that we can contribute, I believe, from the UK is education and training. We have this fantastic history of education and training of health professionals. One of the great, the Brits, the Americans and the French are the great educators in health professions around the world. And even today, our Royal College of Obstetricians, for example, is 50% from abroad. The Royal College of GPs is the accrediting body for all family practitioner services in Southeast Asia, with the exception of Burma. So, we have this great reach and this great strength in terms of education and training, which we should build on, but not necessarily in the way that we've done it in the past. In other words, having people come here, rather more about supporting people in training and education in their own countries, and a theme that I'm going to keep coming back to. So those were two very clear things that were in the report, and a number of other things. But the third thing that I was impressed by and was surprised by is just how much we had to learn. How many interesting things I saw happening in other countries that were relevant. How many of the people, the Brits who came back to the UK, came back saying, well, actually, perhaps we should do it like that. And that's actually what this book is about. It's actually about what we can be learning from other countries who don't necessarily have our resources or indeed our baggage and our vested interests, and are therefore often much better able to innovate than we are. So let me just give you a very quick overview of what I'm going to talk about. I've got to point this pointer at something. That'll do. Okay, so this is the sort of background, if you like, and the starting point for all of this is interdependence. Had I been running the NHS in 1990, I would just have been thinking about what was happening in the UK. If you're thinking about it in running the NHS in 2000, you've got to start thinking about the NHS in a global context in all kinds of ways, starting with the most obvious, which is the fact that the microbe can get on the plane in Cambodia this morning and be in Washington by this afternoon. Or if you like, in the 14th century, was it that Black Death took 3 years to get across Europe? SARS took 3 days to get around the world. We're all equally vulnerable to those diseases. And actually, one of the implications about that is that weak health systems in poorer countries make us vulnerable just as much as they make their own country vulnerable. So we're interdependent in that sense. We're interdependent too in terms of resources, in terms of people. Health workers are the most, the group of staff, or group of people most able to travel around the world, I suspect. And indeed they do. And we all use the same sort of resources and drugs and so on, and of course they're unfairly distributed. But we also now increasingly using the same knowledge base, and we're increasingly interdependent in a whole range of different ways, of which I've just illustrated a few. So our starting point is that health terms, we are now interdependent. My second point is that there is an unfair health trade. Now, I don't know how many economists there are in the room. This isn't a trade, strictly speaking, can I be clear? It's a metaphor. But the basic metaphor goes like this, which is that we in rich countries import health workers from poorer countries, and in exchange, we export our ideas and our ideologies, whether they work or not. And not surprisingly, you will find all over Africa, as people know in this room or indeed other places, you will have British aid workers or development workers who subconsciously have got some images and ideas around the NHS in their mind, which they're talking to people about. And then you'll, of course, come across Americans who've got a different model of healthcare in their mind. And we keep having this sort of supposition that you know, our ideas and ideologies, which may not, of course, have worked all that well in our own countries, are being introduced elsewhere. And I argue in this book, well, what would it be like if we turned it the other way around? You know, what if we started to learn some of the ideas and ideologies from other countries, and what if we exported some of our health workers, specifically to do the training and education that I talked about earlier? So that's the sort of central theme. And as part of that theme, you naturally move into a sense of, let's stop talking about international development and start talking about co-development, and that actually the processes of international development, which are very often top-down and about, you know, a cultural hegemony, if you like, actually, if you start thinking in terms of co-development, you think about it differently and you realise how much you've got to learn. And the other big theme that comes out of that is that I think we're in a transition between paradigms in terms of healthcare. We're moving away, and I'm going to illustrate this a bit, from a very hospitalised, clinical, physician-orientated conception of healthcare to one that is very different and will be apparent over the next few years. So let me just touch on that unfair health trade for a moment, because the examples I've given are not the only examples. I'm going to get there eventually. Clearly there is the issue about how health workers are spread around the world. There's the issue that I've already alluded to of how we unconsciously impose our own ideas quite often about what health systems look like in different countries. And my own experience of that is being in, and I better not mention countries or individuals, but coming across ministers or permanent secretaries in countries in Africa who've got advisors who are either American or English sitting next to them, whom I wouldn't necessarily have employed in my own country, but telling them how to do things in terms of thinking about models that are coming from either the American system or the UK system. We also know that that there's a great unfairness as well in terms of how we handle pandemics, and that interesting example of wasn't it Indonesia, where Indonesia were refusing to hand over tissue from patients for analysis by the World Health Organization so that it could be used for the development of vaccines, which India knew would then be available much more extensively in rich countries rather than in poor countries. And the argument they were putting was actually, well, even in this area of pandemics, you've got to be thinking about how you manage pandemics across the whole world and not having the discrepancy between rich and poor. We know the variation in resources. The example that I often use in this one, which people again will be familiar with, is the contrast between sub-Saharan Africa and North America. Sub-Saharan Africa has, roughly speaking, 10% of the world's population, roughly speaking, a quarter of the burden of disease, roughly speaking, 3% of the resources for health and 1% of the resources for health workers, 1% of the number of health workers. Go to North America, about 5% of the world, about 3% of the health burden, 25% of the resources, and 30% of the health workers. These are enormous differences between countries. If you want to put that another way, there's a big hospital, where I can't quite work out which way we're pointing, but St. Thomas's is somewhere, that way, St. Thomas's. Roughly equivalent to running St. Thomas's, which has about 600 doctors, having the same burden of disease as you've got in St. Thomas's, and treating them with 6 doctors and about 30 other staff, compared to what they've got there, which is 600 doctors plus, I guess, something like 2,500, 3,000 staff. That's the sort of contrast that we're talking about, and know that. And then, of course, if we look at trade, aid, and FDI, if we think about the aid sum, well, most of the relatively small amount of aid in the world goes to sub-Saharan Africa and to other low-income countries, obviously. If you think about the foreign direct investment circle, which is about 100 times bigger than aid, something like 1 to 2% of that goes to sub-Saharan Africa. And if you think about trade overall, then again you'll see that, which is a much bigger volume altogether, then again something like 1 to 2% of money comes to sub-Saharan Africa. So you've got a picture of real unfairness, real inequity around the world, which people in this room, I'm sure, know even better than I do. So what do you do about it? This is where I start to talk about maybe there is a fairer balance, and it is what I've already alluded to, that actually one of the things that we can do, and I've recommended this to the government, and the government is almost, the previous government is almost government policy, is that one of the things we can do about health workers, of course, is make sure that we are doing much more in the way of training and education of health workers, supporting training and education of health workers in their countries of origin. Let me pause there for a moment just to deal with that great issue of migration, which I know people will be saying, but actually, shouldn't you be stopping health workers migrating from poorer countries to rich countries? Well, people may be aware of one number and one policy on this, which I think are probably relevant. The number is that in Africa, something like 135,000 health workers have emigrated from Africa over the last 35 years. If they all went back, that would deal with about 10% of the problem. Migration is important. It is an important leak out of the system, but actually the much bigger issue in numbers terms is not enough people are being trained. And if you just take Ethiopia, and I'm sure you all read the Ethiopian Medical Journal avidly, in January 2008 they did a study of every doctor trained in Ethiopia in the last 35 years, which turned out to be 3,500, 100 a year. Ethiopia is a bigger country than us. They train 100 doctors a year, though it's about to go up dramatically. We in the UK train 8,000 a year. Completely different contrast. So that's why one of the big themes for me is about how we can use our fantastic ability and record in training and education to do more. We can obviously do much more about learning and understanding, and I'm going to give you some examples from poorer countries. And then there's a whole range of issues I'm not going to touch on, but I'm put them up here just so you know that I am aware of them, and they are discussed in the book, of course, which is there are issues about rights, there are issues about equity, and there are issues about transparency, about changing some of this unfairness. But let me talk about health. Let me move straightforwardly onto health itself within this consequence. And in the 20th century, we have had the most fantastic successes. If you're a man in the UK, life expectancy for a man went up from 49 to 79 in a century. That's 30 years in a century. That's 3 years a decade. If you wanted to put another way around, it's 8 hours a day. And you know, you may think that's a good thing depending on what sort of day you had, that at the end of it, you know, you've got 8 hours longer, or if it's been a really dreadful day, you may not feel that. But a most extraordinary improvement that we have seen in health due to a certain number of drivers. I've listed some there: greater professionalism, scientific discovery, commercial development of drugs and so on, and increasing funding. And there's a dynamic that has driven that. Now, I appreciate people here are interested in public health. The clinical medical sides have been a great success, but so is our social policy. And if you look at actually what's driven those improvements, it's not just the clinical things. This is a very brief little sketch of 3 areas: health, wealth, and society, with some of the changes in them that have happened over the last 100 years. So on the health one, it starts in 1900 at the bottom and comes up to 2000 at the top, and picks up things like the new anaesthetics, which were really coming in about 1911, the access for everyone in this country to the NHS in 1948, things like the Clean Air Act, surgery and new drugs all make great differences. But so if you look on the wealth side, did the pensions, which started to come in for the first time in 2011, or if you look at the society side, the equalities issues that came in, the education for all, the increase of education of women, and indeed the franchise of women, have all made huge impacts. So we had an extraordinarily successful century in terms of improvements in health over the last century. But the truth is, life has changed, and we're not seeing the same improvements for the same reasons at the moment, and we've got a health system that is geared to last century's problems. In the 21st century, you can see that there are 4 things that have changed really quite substantially, and that if you're trying to run a health system, you need to think about differently. Firstly, the diseases and conditions that people have and die of have changed very considerably from the 1930s and the 1940s. If you look at what people have died from, but if you look at particularly of the last 30 or 40 years, the increase in the non-communicable diseases, the increase in the chronic diseases, the diabetes, and others that are conditions which actually needed to be treated in different ways from the more from the sort of more communicable diseases and so on that we had earlier in the century. So we've seen a change in diseases. We've seen a change in the way that the patients and the public think about health and their willingness to do what the health professionals tell them to do. People are much more autonomous, want different things. And actually linking it with the chronic diseases above, actually people's lifestyles and behaviours will affect whether or not they get good treatment or are able to benefit from improvements. We see science and technology shifting extraordinarily rapidly. I went to a fantastic talk on Tuesday evening by John Bell, who's the Regius Professor at Oxford, talking about what he was seeing over the next 20 years in terms of the title was Redefining Disease. It was about understanding the mechanics, the mechanics of disease, and understanding therefore where the treatments need to be. And as that sort of knowledge comes into the system, it changes the way people think about diseases, but it also changes the infrastructure you need to treat those diseases. It becomes quite a different way of looking about things. And then you also have the health becoming global in the sense that I talked about, that you can't just manage things within a boundary. So we've got this model which was geared towards last century's problems, and we've got these things which are causing major disruption, and which you can see in the UK, where I was responsible for running the NHS. In America, vast increases in expenditure in both cases, and relatively little output at the end of it, because we're still training to use a model that is very physician, very hospital, very clinically orientated for diseases that are now much more social, where people need to have much more engagement in them, and where science has shifted on from the clinical in some ways much more towards the laboratory. So we now have a situation where the model is part of the problem. Aaron Motsoaledi, who's the Minister of Health in South Africa, produced a very interesting quote the other day, I thought. He was talking about the model of health, he was talking about exactly this problem. And he was saying, look at diabetes. You know, the best thing you can do with diabetes is prevent it. The next best thing you can do with diabetes is treat it. The third and worst thing you can do with diabetes is treat the complications of diabetes. And he said, but look at the way we're organised. The people who try and prevent diabetes are the lowest status and poorly paid. The people who treat diabetes are, you know, pretty well paid and central to our activity. But the people who treat the consequences and the complications of diabetes are the top of the tree. We pay them by far the most, and we give them much more status in the decision-making within the system. You know, it's completely the wrong way around. And I thought it was a very good example of a health minister who was trying to shift the debate in his own country. Now, can I be clear that I'm not anti-science in any of what I'm saying, but actually we need to think about this in terms of a very different way of looking at the world. Now, when you're at a point of this sort of change, you need to be thinking about where the new ideas are going to come from. And they're not going to come from permanent secretaries and the people at the top of the tree, or from the leaders of the medical profession generally. New ideas in any industry come from pioneers, who may be people throughout the area. They come from other industries, learning about how other people have done things. In my view here, you will see more coming from poorer countries, who without our resources and our baggage are inventing and innovating in different ways. You'll see new ideas coming from younger people who are coming at this from a different perspective. And isn't it interesting to see so many young people who want to talk about global health as opposed to clinical medicine, and get a buzz from that around? And this is, you know, in all the rich Western countries. And also a lot of ideas, I think, that are very relevant here are going to come from disabilities and rights groups. So from a very different lot, not from the hierarchy of the medical profession and the politicians and the permanent secretaries. But we can learn from poorer countries. So having said that, let me just put in this quick antidote, which is, let's remember, as I've already said, that actually poverty, social issues, internal and external power relationships are extraordinarily damaging to health in poorer countries. There are those extraordinary shortages of resources and health workers, and people are facing still the increasing problems of non-communicable diseases as well as communicable diseases. I guess a lot of people will be familiar with this map, which is actually countries of the world shown by the number of deaths from HIV/AIDS in terms of the size. Not surprising at all to see Africa in this huge and rather revolting shape compared to the Americas on the left, or Europe shrinking above it. But actually, when you look at the non-communicable diseases, you also get a picture which actually shows that, Africa isn't as small as you might have expected. And India, of course, and further east to the areas where we have huge numbers of people suffering from non-communicable diseases. And if you take Africa and South Africa, again, Minister Motsoaledi would say we suffer from 4 epidemics: communicable diseases, non-communicable diseases, trauma, and maternal mortality, and that we're fighting on all those 4 fronts at any given time. So just remembering and just making it clear that I'm not giving you a romantic story about how you can learn from poor people in poor countries. The context is really serious and really difficult. But despite that, there are some interesting innovations. Some of those are individual innovations. I think there's a number of people in the audience who are in the HIV/AIDS world and will know how much of how we actually treat HIV/AIDS has been learnt in Africa. I saw Michael Kazakhstan talking about, from the Global Fund recently, about the things that have been learned in the African context, which are now being translated back into the Western developed context. There are some specific conditions where individual ways of treating things have developed. Let me just touch on one just very briefly, which is clubfoot, a problem that is relatively not widespread in this country, but is widespread in some other countries. British surgeon in Malawi, faced with a lot of people who needed clubfoot operations, which was a 3 or 4 hour operation. They weren't going to get them. Learnt or relearnt an old technique that was used there of manipulation, whereby instead of a major surgery, you actually, as I understand it, manipulate the foot. So after 2 weeks, you get it to there. After 2 weeks, you get it to there. After 2 weeks, you get it to there. And over time, you get as good a result through that sort of manipulative, safe, cheap process than you would do with your 3 or 4 hour major surgery. That, I understand, has been re-imported into the UK and elsewhere. An example of where, because they didn't have the resources, they had to invent different ways of doing things and bring it back, and it's now the standard proper practice in the UK and the US. Policy initiatives, conditional cash transfers, people will perhaps be aware of, invented in Mexico, now around the world. And indeed, New York City introduced Opportunity New York in 2007 with Mayor Bloomberg specifically saying that he had borrowed the policies from Mexico, and being very clear about how they were doing that. Product development, I think of people like Aravind in India, faced with the problem of large numbers of people with cataracts, and expensive lenses, developing the $2 lens, which is now used in 85% of the world. Telemedicine in places which don't have wires. We're starting to see some interesting things develop. But what's also interesting is business has spotted this. This has been identified by GE. I won't talk about them, but let me just talk about McKinsey's for a moment. McKinsey's at Davos this year at the World Economic Forum produced this map, which actually you don't need to look at the details, you just need to look at the map. This is where they are saying that the 30 most interesting innovations in healthcare are coming from. And just look at the map, you can see that they're around the world. Sadly, I don't actually see any in Great Britain in their list here. But the general point is that people are learning and innovating in lots of different places, quite a lot in India, as you would perhaps expect within that context, but also 3 or 4 in Africa. And the range of things you've got there are product development and services and so on. So there's a lot of things coming out of poorer countries that we need to pay attention to. But more important than that, in my view, is as an emerging tradition. If we think about health systems as being about, GPs and outpatients and hospitals and doctors and nurses and the various bits and financing mechanisms and so on, when you start to look at some other countries, you see that there are some other elements that just don't register in our scheme of things. Partly, it's about much closer involvement of the community, family and women. And if you think of somewhere like BRAC in Bangladesh, you'll see that not only do they do that, but they link health with education and with work and with income. They don't separate off health as an industry on the side that's looked after by doctors and nurses on our behalf. They actually are as likely to want to work with a woman with her sick child about educating her and her opportunities, and maybe about making links into microfinance and enabling her to get an income, and therefore enabling her to support her child and improve its health. Health has not been segmented off in the same way as it is in our country. Social enterprises, again, BRAC is a good example of using business methods for social ends. Much more linking of public health and clinical medicine. We do that better in this country than some, but the Americans completely separate that. But one other thing that is a real theme here is the training for the job, not just for the profession. And what I mean by that is the example of Mozambique, for example, where technicos de Chirurgia, who are mostly nurses with a bit of additional training, do 97% of the Caesars outside the capital. It's been studied over 20 years by a Norwegian group, and it shows that the results are just as good as if they were done by physicians. They show they're half the price, and they also show, of course, that the technicos de Chirurgia stay, whereas actually the doctors migrate. You can take lots of other examples like that. I happen to chair an organisation called Sight Savers, and one of the things we do is train cataract surgeons in 3 years. And their results as cataract surgeons are just as good as physicians. And again, they have these advantages of being cheaper and more likely to stay in a country. Now, this sort of stuff I see as starting to be an emerging tradition, as I call it, to set aside the tradition we've got of our very hospital and physician-focused health systems in the West. And let me just one more word, I think, on that particular point about staffing. We have a health system which is a pyramid of staffing, where we have a very large number of very senior people. And we make a virtue of that in many ways. We talk about consultant-led health service and so on. But the reality of that is we have people at the top of the profession who are actually working below what they've been trained to. So you actually do get the ophthalmologist doing an awful lot of cataracts, whereas actually they're capable of doing much more interesting and complex things. If you look at Africa, you will see a health pyramid with a much smaller top. You still need the top, you still need the specialists, you need people right the way through the system. But it's a question about proportions between them. Now, I'm not for a moment advocating, I wouldn't dare, that all Caesars should be done by nurses with additional training in the UK. Maybe they should. It's for other people, I think, to take a view on that. But my point is that actually it can jolt us into thinking about things in a different way. And just because we've always done something in a particular way, we can actually start to be more creative and think about how we might do things differently. I said this to an audience in Edinburgh, and a young doctor there, who was actually, as it happens, an ophthalmologist, said, "But we can't have nurses doing cataracts because how will doctors learn to do them? We need to do all the cataracts for training purposes." And it was a classic sort of professional response, that actually we need to be able to treat patients as doctors, because otherwise we're never going to learn. Well, what was the aim? Was the aim to provide service or to train? Now, I know you need to get those things in balance, but that's the sort of tension that you get into. So moving on rapidly, let me also just pick out one other point that I think is really significant here, which is actually what's the point of healthcare? What's the point of health? We will mostly think of it in terms of treating disease and so on, but actually I suspect there's a very important bit about interdependence or autonomy. It's about seeing the world in terms of people's lives, not our services. And very often you will hear what people are actually wanting from the health system is the ability to live a life that they have reason to value. They want to get over this particular problem they've got at the moment, and they want to manage their disability and be able to get home. And if you look at our local hospital here at St Thomas's, biggest issue there will be elderly people with multiple pathologies. And the issue for them may be treatment of their individual clinical thing at that time, but actually, in many ways, the most important thing is, can they get back home, and can they get back to being independent, and can they get back to living their lives? And it's the sort of language we use when we're ill. We want our life back. There's a whole set of different ways of thinking about the world. If you think about a lot of what healthcare is about, it needs to be about helping people to be living the life they have reason to choose, reason to value, and doing it independently. And really important in our British context, that we get health and social care alongside each other. I have a friend who's a doctor in Alaska who talks about, this primary diagnosis, he says, is almost always social. The old man in front of me may have Parkinson's and I may be able to give him the medication, but the real issue is he's not washing, he's not eating, he's lonely. How do you deal with all of that? How do you think about that? And that's about his ability to live by himself. So let me move on from there. So if there's an argument, as I've attempted to make it, that actually we've got a lot to learn by being much more humble about our approach of working with others. Some of it's specific, but some of it, I think, is about a new tradition, which wouldn't be surprising, that is growing up in other countries around the world from which we can learn. Then that, of course, moves us on to the notion of co-development. And this is where I get rude in this room, I suppose, rather than you know, we've had this sort of top-down development with Western experts, and even, I have to say, what I have seen around Africa and what my colleague Susanna has seen around Africa of us as Western experts trying not to tell people what to do, get into it really quite easily if you're not careful. And we have had what I would call the invention of international development. And I think the point that I'm really trying to make here is that around Africa and elsewhere, I've seen quite a lot of people working in health who are development people who've learned something about health. But I think there's a big role for health people who can learn something about development. And that actually, if you're talking about co-development, it's doctors talking together. It's actually, you know, the doctor in Gonda in Ethiopia, who we'd really like to talk to, is somebody who deals with chronic diseases at St. George's, at St. Thomas's, and will help him to think about how to manage his clinic. Doctors, I can see people nodding. Doctors, like most professions, like talking to themselves, if you see what I mean. There is a bit here about, do we do enough to actually put the professions together and let them grow and learn from each other? And I think that's a very big theme that we need to think about. And my final point there is that is the importance of everyone understanding global health. And indeed, I've got a debate in the House of Lords coming up on this in the not too distant future, that all professional education should include an understanding of global health with all the dimensions I'm talking about. Quickly moving on to, if we do think about co-development, what are the benefits? Well, there are some pretty obvious benefits for poorer countries. Things become much more country-led and owned. They become much more culturally sensitive and respectful, able to draw on all traditions, which is a really important theme, rather than just imposing ideas from outside, avoids the faults and weaknesses of our problems. Certainly poorer countries can learn from us, but they need to learn where we went wrong as well as where we went right. And it also recognises, frankly, the shifting balance of power and the fact that it wouldn't be surprising, would it, that new ideas are coming from elsewhere other than the Europe and America. But what are the benefits of co-development for us, which is part of my argument with government, both the current government and the previous government, and starting to make an impact. Very much this issue of refreshment and personal development I talked about to start off with. People get a lot out of it. Greater cultural awareness. If you happen to be working in the East End of London, it's probably useful that you understand something about Bengali culture. And indeed, we've got a really interesting partnership between the northwest of England and the northwest frontier in Pakistan, where there are obviously some links between populations, but where they're learning from each other. Learning some specific skills and practices that I've talked about. This bit about challenging our long-held ideas, you know, not only taking off your NHS glasses, but taking off your NHS glasses inside your head. You know, you didn't always have to do it like that. And then gradually, you know, shaping the future together. It's actually the health workers around the world who are going to shape things and make things happen. And this is starting to happen, in my view. I think you're already beginning to see what I describe as a movement of people and ideas. A lot of innovation happening all over the place. Young people, as I said, seem to get it. They want to talk about global health. They want to see themselves as interlinked with the rest of the world and not just citizens of Dartford or Birmingham or wherever. And I think we're beginning to see what I would describe as a new paradigm. Not throwing out the good things of professionalism, the fact that our doctors are highly professional as opposed to sort of pre-1910, pre-Flexner quacks in some cases, you know, good scientific basis, the fact that scientific discovery is taking us forward, the fact that commercially you can develop drugs, the fact that you can get more funding in, these are all great, but they do need to be added to, in my view, by a better understanding about this issue of interdependence for all of us. This issue about what people want from health very often is independence and ability to live their life, and also this understanding about rights. And that somewhere out of that, we're going to start to see a new paradigm emerge. And finally, I'm optimistic. I think things are already happening, as I say. And the issue is, how do you accelerate it? I think one of the things you do is make it visible and coherent. Point out these people who are doing all these things around the world, turn it more into a movement. I think very importantly, this issue of health worker education and training. I've been advocating again and doing a bit of getting more British health workers involved in training and educating health workers in other parts of the world. It's a terrific two-way exchange. People learn from that. Two-way exchange, and also, to some extent, of course, it's paying back a debt for the number of people who've come the other way. And I think this final point, that actually an awful lot of this is creating the opportunities for experience and exchange. For health workers who now live in an interdependent health world, to have the opportunity to exchange and to link much more with people who may be in different bits of the environment, but they're in the same world. So finally, we're in this together. It's not just about disease and resources, but about learning and sharing. And it's not about thinking about health separately in rich countries and poor countries. There are differences, but there's huge overlap between the two. And it's not just about sort of confronting occasional Western arrogance, but the trouble is that our current health systems, as they're organised at the moment, are in danger of going down a dead end. So thank you very much indeed.